Well, welcome to another Providence Grand Rounds. We have a fascinating topic today, understanding the role of advanced practice providers and how they influence health policy and practice. Next slide, please. Some logistics that you're probably familiar with if you've joined before. All attendees are muted, and we ask that you use the Q&A box to ask questions or share comments, although we will be monitoring the chat as well. This presentation is being recorded and will be posted on the Grand Rounds site for later viewing. Next slide. We are offering continuing education, and you can see the options projected there. And if logging in for CME, you do need to use that specific code that's posted, and that will be placed in the chat as well. Next slide. This is a list of the planners and presenters, and none of the planners and presenters today have a relevant financial relationship that would be a conflict of interest. Next slide. And it's my pleasure to introduce Christy Carrington, the Regional Chief Nursing Officer from Swedish, who will lead us in a reflection today. Christy.
Thank you so much, Michael. And thank you so much for inviting me to be here and share my reflection. So you can go ahead and advance to the next slide. So, you know, one of the wonderful things about being a part of an organization that has been a pillar within our community for over 100 years is that oftentimes there are community members who will send in or share items that they find as they're kind of rummaging through, you know, old personal items or family heirlooms. And this picture that I have is a picture of the Signal, which in this case, you can see it was written 100 years ago. And it was the annual publication for the Swedish Hospital Training School for Nurses. And I found myself thumbing through this one day a few months ago, and was really fascinated by it because it includes a lot of photos and also the writings that were submitted from nursing students that were a part of the program. You know, and as I was reading through the publication, there was actually one entry in there in particular that really struck me. And what it spoke to were the trials and tribulations of going through the training program. But it also went on to talk about what it was like to be a nurse in 1922 and what the characteristics were of nurses who were entering into the profession in 1922. And the writer elaborated on, you know, the humanity, the compassion, and the boldness that it takes to be a nurse. And then it went on to read, on the next slide, you'll see an entry there where it said, "Stick to it." And so the quote there is, "Many the night does she come home too tired to talk, ready to quit and give up, yet there is something that binds her, something that is alluring yet hard. Indeed, stick to it is the only motto I know worthwhile. To stick to it, to smile even when your heart is breaking, your back is breaking, or something breaking. To fall once is to fail once, is to fail again, and it makes it just that much easier next time." And so as I read this, it really made me appreciate that even 100 years ago, healthcare was tough. It was hard. And I think we could probably all reflect today on where we are. It's never been harder. And it highlights to me the perseverance and grit that it takes to work in healthcare, and that we always do our best to get it right. But when we don't, we learn, we improve, and we do it better the next time. And so, especially as I reflect on the last 2 years and where we are today, it's really allowed me to have this profound appreciation for the humanity, the compassion, and the boldness of the people across our organization. And I've seen us persevere through the challenges of the healthcare environment, and of course, what lies ahead of us as well, but also just through using continual improvement and just doing the right thing. So I just wanted to share this reflection with you and also express my gratitude to each and every one for your humanity, your compassion, your boldness, and most of all, your perseverance. Thanks so much for allowing me to share this reflection.
Well, thank you, Christy, for that uplifting and illuminating perspective going back 100 years and the incredible role that the nursing profession provides in caring for our communities. So for our topic today, understanding the role of advanced practice providers and how they influence health policy and practice, we have two well-qualified speakers. And I'll just give brief introductions right now before they begin. First speaker will be Cindy Warburton, who's a doctor of nursing practice and family nurse practitioner, and the program manager for the APRN fellowship program in the Clinical Academy of the Providence Nursing Institute. Committed to ensuring advanced practitioners are prepared and supported as they transition into practice, her role includes developing a program to ensure their success. She continues to practice herself as a nurse practitioner in urgent care in Spokane, Washington, and is an assistant professor at Washington State University. And then following Cindy, Justin Gill, also a doctor of nursing practice and FNP, is a family nurse practitioner practicing at Providence walk-in clinics in Everett, Washington. In addition to his clinical work, he serves as a health policy lecturer at the University of Washington, Bothell, vice president of the Washington State Nurses Association Board of Directors, and a board member for ARNPs United of Washington State. Justin believes that clinicians should play a greater role in health policy development. He views health policy advocacy and clinical practice as synergistic, not mutually exclusive. So we look forward to the presentation today, and we'll turn it over to Cindy. Next slide, please.
Thank you for that introduction.
And I missed up because I do need to talk about the learning objectives too. I'm sorry. So
I was going to cover them. Go ahead.
What? You can see the learning objectives here for today's presentation, but I'll turn it back over to you, Cindy. Thanks.
Yeah, no problem. Thank you. So yeah, we're going to talk a little bit today just with a brief background on nurse practitioners and physician assistants and the role that they play across Providence. And we'll talk a little bit about those challenges and opportunities as new advanced practice providers, or APPs, as they transition into practice and what the clinical academy is developing to meet those needs. And Justin's going to talk about the how education and preparation of APPs and NPs and how that plays such an important role in their ability to influence and shape healthcare policy and analysis and direct the patient care, and specifically for COVID response that we've all been experiencing. So, and also how this impacts the development of solutions that drive change in population health and the social determinants in healthcare. Next slide, please. And so nurse practitioners, there's more than 325,000 NPs that are licensed across the US. About 90% of those are certified in primary care. Excuse me. The rest being in other specialties such as pediatrics, adult gerontology, acute care, CRNAs or nurse anesthetists, and about 45% of those hold hospital privileges, and with about over 96% of them prescribing medications, including controlled substances, and the average NP has been in practice for about 11 years. Physician assistants are very similar. There's about 150,000 practicing PAs across the US. They too practice in all types of settings and specialty areas. And the education and experience, as you can see on the slide there, is similar. However, the clinical practice hours are different. And that's mainly due to the requirement of RN training and licensure before starting an NP program. And then physician assistants typically have some experience with patient-facing roles such as EMTs, CNAs, scribes before they start their program. And of course, RNs are licensed. It's a requirement with a BSN before starting a program. And then once graduated and licensed, both NPs and PAs, they're ready to practice. However, there are growing movements to provide transition to practice programs, fellowships, and residencies that will help give support and specialty-specific training as they enter into practice. And next slide, please. The licensing for NPs is very different than PAs. So you can, the state boards of nursing oversee nurse practitioner scope of practice and whether or not they can practice independently. State board or state medical boards oversee physician assistants, and therefore their scope of practice and licensing oversight. And half of the US have states where NPs can practice independently. So that means that an NP can practice to the full extent of their Nurse Practice Act, and the scope of their practice is supported by the regulations in that state. And then other states, in the yellow and red, have reduced or restricted practice and oversight. So that means that there may be a requirement to have collaborative agreements with physicians. The NP can operate under limited scopes of practice. And physician assistants are also seeing changes at the state level for their practice and oversight. For example, in Oregon, starting this year, they're moving from a supervisory role to a collaborative model. And I think we'll start seeing more changes across other states with that as well as it gets implemented. Next slide, please. And nurse practitioners and physician assistants are employed across the Providence system and the ministries. And I apologize, I don't have all the numbers representing PAs. So the numbers here are only for the NPs, and across the system, there are over 1,100 NPs working in a variety of roles and specialties. Of those, 80% are outpatient based, typically in primary care, urgent cares. The acute care network, you can see, has quite a bit of a PA or NPs working with them, and about 20% are based within hospital settings. And you can see that there's a lot of different specialties that NPs and PAs practice in. Primarily, though, urgent care, express care, primary care, that's where the background and the training it comes from. And then depending on backgrounds, they may go into specialty care, cardiology, you name it. Any of the outpatient based clinics is where you will find many NPs and PAs practicing. And while NPs and PAs are ready to practice once they're licensed, like I mentioned, we are seeing the value of adding transition to practice programs. And next slide, please. I'll talk a little bit more about that. So the Providence Nursing Institute has supported the Clinical Academy in the development of the first advanced practice or TIP program, which is a transition to practice one. It's focusing on core curriculum for supporting that transition to practice phase, usually within the first 12 months of their job. So it's designed to provide that postgraduate professional development for NPs and PAs as they begin working in the clinical setting. And the goal is to really help them build confidence and competence, give them support that they need to thrive and grow professionally. And to be engaged within Providence, and designed to work in partnership with the clinical sites. It's a crucial component of that onboarding process, and really a a complement to the specialty clinical training and curriculum if it's available. And so we launched our first pilot cohort in early January, and we'll be launching a second one in June. And at a glance, you can see that blue section is a high level outline for the TIP portion of this program. And the sites will collaborate with the Clinical Academy on enrollment, preceptor identification, mentor support. There's asynchronous modules that are delivered over a virtual platform, and it aligns with peer connect sessions where we do hold a virtual live meeting where we can connect and we cover different topics. And some of those topics include autonomy and confidence in practice, stress management, clinical reasoning skills, clinical scholarship, and professional development. And St. Joe's in Southern California is one of our primary pilot sites. They've created the specialty curriculum component, and you'll see that is in that brown shaded box there at the end. And so what that is, that's the clinical piece of this training program, and it's going to be very site specific. And so for St. Joe's, they have a 6-month didactic piece where they cover primary care and urgent care. And again, those being the two most common places where you'll find APPs, and the education is provided through third-party content and then didactic days where they have their local practitioners come in and teach hands-on procedures and various topics. So again, the long-term goal here is to achieve accreditation for this program and get it rolled out across the system so we can really support advanced practice providers. And as I wrap up, I think it's so important to recognize that these programs would not be possible without the strategic site and the overarching support at the system level. And so we really look forward to developing more robust programs that can elevate, retain, and celebrate advanced practitioners across the system. And Justin, I will turn this over to you.
Awesome. Thank you for that, Cindy. And I think that, you certainly highlighted a lot of the points about how, how nurse practitioner education, as well as other advanced practice roles, kind of that transition towards practice is an important piece in that individual's career. So I'm going to take kind of what Cindy had talked about as far as the background of nurse practitioners and advanced practice providers, and kind of the background that they may have or preparation in their education on health policy integration and health policy awareness. There is a growing trend towards the Doctor of Nursing Practice degree as the entry level for nurse practitioners. Currently, it is a requirement that an individual has a master's degree in order to sit for their board exams. But there's this kind of growth even at the University of Washington, and many of the local schools are kind of moving towards that 3-year Doctor of Nursing Practice degree, which will have more clinical hours associated with it. And I think that that's something that nurse practitioners coming out of school would certainly appreciate. But it also really focuses on integrating health policy, leadership, and utilization of evidence and implementing a change in order to improve clinical or policy outcomes. And as mentioned in the introduction, one of my core beliefs really is that health policy and clinical practice are not mutually exclusive, but they're synergistic. I was just looking at actually a study from University of Wisconsin that actually surveyed physicians and their kind of engagement in health policy. And only 15% of those surveyed and that responded indicated that they were engaged or at least aware or following health policy news. And the biggest thing for them was just not having an awareness of how they could get involved. And it was oftentimes seen as kind of like a separate thing from their clinical practice. But I think for many of us, we are aware of the fact that, policy really drives almost everything that we do in the care that we provide. Whether it is if our patients are insured, or if they have access to resources in order to adequately follow up with a clinical care plan. So many times it's the most important factor, if not an equally contributing factor to the success of providers nationwide. Some examples of just health policy at the federal level, I think COVID-19 is certainly a kind of reminder for us of some of the deficiencies that our healthcare system has systemically and kind of long-term issues that have been exacerbated by a global pandemic. Social determinants of health, looking at other issues, not just issues that are directly related to healthcare delivery, but issues that affect economic security, racial equity. You look at socioeconomic status of individuals and how you can help their clinical outcomes by addressing some of those external factors. We look at access to health insurance and care. I think for many of us, at least in the primary care setting, can appreciate that when the Affordable Care Act came in, there was a lot of changes in our day-to-day work, a lot of changes in what types of things that patients had access to, as well as a lot of issues during the implementation of that, which really impacted health providers and the care that patients got. Another key part of advanced practice education is looking at the systems level, so systems level thinking. And when I say systems level, it really means using the system surrounding the patient and how the role that plays. So like, for example, understanding the efficacy of a medication or treatment is very important. But the ability for that patient to be able to afford the medication is another story. And oftentimes that's the dominant factor in whether that patient decides to take the medication or not. Next slide, please. So recent health policy events locally here in Washington, and these were things that really did impact the care that I provided, was the Office of Insurance Commissioner actions, which is a regulatory agency under the governor of Washington, and requiring health insurance companies to cover COVID-19 testing for a long period of time, although that's kind of faded away a little bit now. You look at the CARES Act, the American Rescue Plan, some of those funds that are vital to keeping our health systems and infrastructure up and running. One particular bill that I found interesting was the Washington State House Bill 1152, which actually did pass, addressing local boards of health. For those of you that live or in Washington State, you're probably aware of our public health system and sometimes the politicization or the controversy surrounding many local health officers. In the eastern side of the state, there was a health officer that was fired for his positions on mask mandates and utilizing the best available evidence from national public health resources. So that was an action that really kind of helped support science-based and health professionals being in those local boards of health. So that way you have policy that is driven by the best evidence and the best clinical care, not necessarily the best politics. Executive orders, I think, are the most relevant ones that we can really kind of feel when it comes to mask mandates or mask requirements. And that is really something that's driven at the state level, and it really does impact kind of our workflow as clinicians. Working in an urgent care setting, I can definitely tell you that policy actions like vaccination requirements or mask requirements, they impact the patients that are coming into my clinic and the number of cases that we see. We look at CMS coding changes. I think for many of us in this past year, it's been kind of a steep learning curve, but that really is rooted in health policy. Large organizations came together over a multitude of years and changed the way that we code for or bill for our services. And I think that what I do hear oftentimes from clinicians is that there's frustrations with almost every policy measure or policy act. But I think it's important for us to recognize that we actually can play a much bigger role in affecting change. And if we're just aware of those resources that we have to be able to let our lawmakers or our policymakers know what is it like on our day-to-day work and what are some of the issues that we face. Next slide, please. So I always like to look at kind of policy, healthcare policy and clinical practice in two different ways. And I think that there's definitely different processes that are involved when it comes to implementing policy and how you actually integrate it into clinical practice. So policies really are developed kind of either at the governor's office, at a regulatory agency, sometimes even at your local boards of health, and oftentimes is introduced by a lawmaker who has heard about issues with patient care or met with one of their nurses or physicians about a clinical issue that they were facing. And that development really includes a lot of other voices and groups at the table. But what I like to tell people is the development of good policy requires the involvement and active participation of the people that policy will directly affect. And having a sense of apathy or I would say kind of not really having much interest in being a part of that process can affect the effectiveness of those policies when they actually are implemented. We look at policy implementation. That's another piece where, after a law or a policy is adopted, how it actually gets implemented and kind of the nuts and bolts of putting that policy into place. Those are huge actions that still require input and advocacy and involvement by frontline clinicians. And then there's the integration of those policies kind of into that clinical practice setting. So when it comes to, for example, the insurance requirement to cover testing. That was a huge issue for our clinic, where in our urgent care setting, we had many patients that would ask that question, is my insurance going to cover this? And that would affect their ability to actually consent to having a test done. Or just coming into the clinic, for the first time in many years because they wanted to get testing, and cost was a major issue for them. So actually researching that, looking at the Office of Insurance Commissioner statements that went out, I was able to look at, developing some tools to give to some of our other providers in the clinic, so that they were aware of what the current policy is. And I think that that's just as important as being aware of treatment guidelines and COVID guidelines, because again, patients, they're not going to necessarily do the right clinical thing if they don't have all the tools and the resources available to them. Next slide, please. And then we look at practice to policy development. And this is really where we're looking at those of us that are on the front lines and are dealing with seeing patients, whether you're in a primary care specialty or in an inpatient setting. A lot of those experiences that we've had, and I think going back to COVID as an example is really important, because a lot of those experiences we have are very, very rich, and they are at many times difficult for us to process. But the problem is that many times those people that make those decisions or introduce legislation or come up with policy changes don't have the awareness of what those issues are. And oftentimes that responsibility really does fall on us as the frontline clinicians to be able to facilitate that communication and let those leaders and lawmakers know what actually is the issue. And then there's advocacy and engagement. I think for all of us here, we've kind of, there's so many ways that you can be involved. And I always like to reinforce the concept of voting is kind of our power that we have as a large block of healthcare professionals, and engaging. So, reaching out to your lawmaker, your local lawmaker, your city council, for coffee or something like that, just so that way you have the ability to meet with them and they have the ability to listen to you about what your concerns are. One of my favorite quotes is that if we are not at the table in those discussions, then somebody else is very happy to speak for us. And sometimes is good to have that diversity of opinion, but if we're not there at the table, then we can't expect all the policies that do come out to be as effective as we hope they could be. And then we look at changes that are made at the local, state, and national level. When it came to incentivizing, say, healthcare providers for counseling on vaccination, those types of things that we really, as clinicians, could feel and really understand that these policy changes were not just impacting the health system, but they were impacting the care that I was providing. Okay, and next slide, please. So, anytime we think about health policy and I would say policy change, it's definitely important to focus on the policy itself and the care that we provide, not necessarily the politics that sometimes invades those spaces. I think for many of us, we can all agree that healthcare has become increasingly political. I see this in my clinical practice on a day-to-day basis where folks will have kind of a persuasion or a kind of preconceived idea of what it is that healthcare does for them and what they should do and kind of what society should do to impact healthcare. And a lot of it is kind of guided by misinformation or politically motivated recommendations or politically motivated statements. But the political process really, I think it oftentimes kind of gets a very bad rap, and that's understandably. It's one of those where people perceive the political process as something that they don't want to be involved in. But the reality is that political process can be influenced by healthcare organizations and providers like ourselves. We just have to have the engagement and the awareness to be able to go forward and be a part of those organizations and advocacy efforts. And issues affecting patient care, really those transcend political identity. I think, COVID-19 really has been a reminder for all of us that it doesn't care what our race is, it doesn't care what background we come from, it doesn't care what our income bracket is, but it does affect certain groups a little bit more than others. But what really goes to this is that the politics really has nothing to do with the clinical outcomes for those patients. It is really the best care that we know as clinicians. And how we kind of cut through all of that noise is really important, not just for our own professional job satisfaction, but also for giving good care to patients that's grounded in outcomes and not politics. The next slide, please. So clinical practice pearls, I always like to kind of give anybody that I talk with about advocacy and just health policy some resources. One really important resource that I've actually been able to give to many patients in my urgent care setting is the Washington Health Plan Finder website, where people who are uninsured can sign up for health insurance. And what a lot of providers actually aren't aware of is that if patients are uninsured and they're, say, hesitant that they don't want to get blood work done because they don't want to, they can't afford it, or they can't pay for a certain medication, or they're worried about a certain workup. If they qualify for state Medicaid, they go to that website and they get approval based on putting in their income information and all of that. You oftentimes can get those services for that same day covered retroactively. So many patients oftentimes aren't aware of that, but just giving them that website gave them the confidence to be able to move forward with doing what was best for their clinical care. And that really changed the kind of the trajectory of that workup. Healthcare.gov is the national website for those of you that are out of state, and that will forward you to a state website for their health insurance exchanges if that state has one. But that oftentimes can be the website that you give to patients if you're not sure what the state has. I really like this ACA, the Affordable Care Act Marketplace Calculator. It really helps with understanding what are the pieces with health insurance and kind of understanding, what is the deductible? What is the out-of-pocket maximum? How is that affected by certain policy changes that have happened? Because that impacts also the decisions that those patients make. And so the other piece with this is that compliance with the care plan, and I think we've all kind of seen this if we're seeing patients, is really enhanced by health coverage. And there's a lot of data on that. A study by Summers in 2017 really looked at kind of the compliance with, say, hypertension, diabetes, high cholesterol, and the insurance coverage of that patient. And I think it's understandable for all of us to see that those outcomes were not necessarily the best in folks that were not covered by a health insurance plan, because people will oftentimes perceive health care delivery as a commodity or kind of like a service that you're paying for because you are paying out of pocket. So those asymptomatic conditions that are really important oftentimes are neglected. Consider being more involved in your professional organization. For nurses, your state organization or your APRN state association, national professional associations, to learn more about what national issues are going on. For our physician colleagues, the medical association, the Washington State Medical Association has been on at the table on those discussions about COVID relief, personal protective equipment, and providing support for our health systems. Always kind of really think about those barriers and ask yourself those questions of, why is it that we are apathetic about being involved in health policy at whatever level it is that you're comfortable doing so, and that we really kind of don't have that close connection or the connection that we should have with those decisions that are made at a state or national level. And how can we address, the lack of awareness of what resources we do have to be able to affect change that is positive for patients and providers. Okay. And that actually is the end of my section. So I wanted to see if we could open it up for if there were any questions that had come up.
So there is a question that came in through the Q&A. This may be for Cindy or either of you. It said, will you be including clinical nurse specialists in the TIPS program since they're also advanced practice RNs?
Yeah, thank you for that question. And so we're very much in the pilot phase of developing this program. So we intended to only have maybe 4 participants, and we have 10, which was, it's exciting, but it's also the long answer is not for the pilot program, or I should say the short answer is not for the pilot program, but the long answer would be yes, to consider CNSs down the road once we get through this pilot phase, because that looks a little different, just given the differences between how they practice, maybe in acute care versus, as an NP and outpatient care. And so that's sort of a short and a long answer for you. And I'm happy to clarify if you wanted to add anything else to that question.
Well, while we're waiting to see if there is a little follow-up message. Let's see. No, they said thank you. Perfect.
Good. More to come.
In the area of policy or advocacy for either of you, but perhaps Justin, I noted in the introduction that 2 of the states in our system, California and Texas, have restricted practice. It's not independent. And I wonder if either of you, I realize it may not be from geographies that you're familiar with, but are you aware of advocacy efforts to expand the practice roles?
Yeah, Cindy, I don't mind taking this one, or at least from the start. Yes, there's a lot of effort statewide, and actually, that map that Cindy was showing earlier, it changes like week to week or month to month. Each state really has their own kind of unique approach sometimes to full practice authority. In California, for example, there was a recent bill that was passed that allows nurse practitioners to practice independently with a 3-year supervised transition period. But this kind of goes back to that whole being a part of the development process, because one of the pieces with that legislation is that if you're an out-of-state nurse practitioner that, say, has practiced for 5 to 10 years and you move to California, that ability to practice independently, you have to kind of restart and have those 3 years of supervision from a physician that is licensed in California. And I think we can all kind of see that as a very inefficient policy kind of consequence that came about that. Florida is another one that's recently changed, where nurse practitioners can have independent practice in primary care specifically, but it requires some additional CME as well as proof of clinical hours, which I believe is at least 1 to 2 years of clinical practice hours. That does honor out-of-state practice as well. Cindy, I wasn't sure if you had anything to add on that.
Yeah, I guess the only other thing I would add is that the pandemic has highlighted many issues that were there before in terms of barriers to full, practicing to the full scope of practice and these regulatory oversights. And so it's highlighted it and has sort of fast-tracked in many states, removing those barriers. And many states removed them from under emergent rules in order to allow NPs to increase the access to care. And then they have been since, went back to normal. And so those states now have opportunities to, well, let's look at the outcomes from that. Is there really a good reason to continue with these restricting laws when we have proof that, it really increased access to care and improved patient outcomes by lifting them, and so they can see that across their states. And it'll be interesting to see how this map changes as those rules and regulations are reassessed.
Great. One other question I had was whether you both might provide your perspectives or comments on what are we doing nationally or specifically within Providence to increase the pipeline of nurse practitioners and maybe even upstream encouraging more people in the nursing profession because of the options to be independent practitioners eventually.
I have some thoughts on that. I'll go first. I think that in terms of the pipeline, and I'll say this from my narrow view and experience from the academic setting, is there is a lot of interest and applications for school for NPs. Like our pipeline is still consistent for the most part. I think that what we're going to find is a movement, just like Providence is doing, towards programs that support that transition to practice piece so that we can keep a sustainable workforce and give them the support that they need as they get into practice. And from a Providence standpoint, I think, there's a lot of activity going on to support from a system level, as well as what I'd call the foundation from the clinical academy piece, which I already shared, that transition to practice piece. And as we move closer to an accreditation to include clinical accreditation in that, but from the system level, there's the Advanced Practice Provider Committee or Council is getting started this month. In fact, our meeting is this week to kick that off. And so that is a system-wide committee that will support advanced practice throughout the whole system. And so I think that you're seeing a movement towards the full package, if you will, of support for advanced practice providers. And, the research is clear on the value in terms of patient outcomes and high quality care and health outcomes that APPs can bring to healthcare. And so I'm just looking forward to continuing to move that trajectory forward.
Yeah, and just to add to what Cindy had mentioned, when we look at kind of the preparation for nurse practitioners, and I would say all kind of advanced practice clinicians, just looking at the financing for those people to go through another very extensive graduate program, and even the public schools. I mean, it's a graduate program, so it costs a significant sum of money. But being able to support them in their ability to practice and pay down those student loans, which many of them will take. There's a health professions loan repayment program. And specifically, there's one for the Nurse Corps loan repayment, which does include advanced practice nurses. I actually just finished an application for that right now. But many nurses, I think, and nurse practitioners may not realize that there are those resources available to them. And that, the health system certainly can support them in accessing some of those resources. And then really kind of looking at getting nurse practitioners and PAs into the clinical areas where there really is that need too. How do we incentivize them to go into primary care or go into behavioral health or some of those more challenging clinical environments? And, a lot of that statewide, when we look at access to behavioral health care with psychiatric nurse practitioners or primary care access, especially in those very rural areas where there may not be very many primary care providers, how can we incentivize those nurse practitioners to go into those clinical areas and actually provide the care where it's really needed? Those are two big issues for nurse practitioners during their education as well as when they come out from their education.
Thank you.
I did think of one other layer in there, Justin. You helped me think about this, but also, I think we're going to see more movement for advanced practitioners in leadership roles, which will be really important in supporting and, sustaining that pipeline of practitioners. And so there's a lot of opportunities for models for partnering with medical directors, having a physician and an APP working together that so that they can really support those APPs in practice, because there are some differences, right? With the, nurse practitioners are really, they're regulated by their state boards of nursing, and then that's very different than the medical boards of nursing. And so having that partnership in leadership roles can really help create some sustainable support.
Yeah, great addition. Well, I don't see any further questions. I want to give a deep thanks to our two speakers for their informative and thought-provoking presentations. And we're all grateful for all that the nursing profession and advanced practice providers have done to support all our efforts to serve our communities at these times. So we'll give folks a little time back. I suspect that with the current COVID surge, we can all use a little extra time between this and our next activity. So thank you again for joining us. And again, really appreciate the great overview and presentation that you provided.
Thank you.
Take care.
Thank you.